Welcome everyone to this focused deep dive. We're aiming this squarely at you, our vascular surgery colleagues, digging into hemostasis and thrombosis management using Rutherford's latest edition.
That's right. We're looking specifically at chapters 38, 39, 41, 42, and 43.
Yeah, a good chunk there.
It is. Our goal is to kind of synthesize all that dense information into a practical, usable guide for your day-to-day practice. Think actionable strategies.
Okay, so where do we start? Maybe preoperatively.
Yeah.
Chapter 39 territory.
Makes sense. Preoperative assessment is fundamental. Chapter 39 really hammers home the need for a detailed history and a thorough physical exam.
What kind of history details are we talking about? Beyond the obvious, maybe.
Well, obviously previous bleeding, surgery, dental work, even childbirth. But also ask about things like easy bruising, frequent nosebleeds, things the patient might dismiss.
Right. And family history is key too, isn't it?
Absolutely. And don't forget medications, not just prescription anticoagulants, but everything. OTCs, herbal stuff.
Aspirin, NSAIDs.
Exactly. Even some supplements can interfere,
Yeah.
Then the physical exam looking for petechiae, unusual bruises, any signs of liver disease, joint issues.
Clues that might point to an underlying problem.
Precisely.
Rutherford's uses a risk stratification system, right? Levels I through 4. How does that help guide us?
Yeah, it's quite useful. It helps tailor the lab workup based on the patient's bleeding history, or lack thereof, and the type of surgery planned.
So, level 1, low-risk procedure, no history.
Typically, no specific hematologic workup needed beyond maybe standard hospital policy. Think superficial lesion removal.
Okay. Level 2, major surgery, but still no bleeding history, like a lot of our open vascular cases.
Correct. For level 2, the recommendation is usually just the basic screen. PT, APTT, and a platelet count catches most major underlying issues.
Makes sense. But what if the history is positive, or the surgery itself poses a high risk? That's level 3.
Exactly. Level 3 is where you have that history suggesting a potential bleeding disorder, or maybe it's a procedure known to mess with hemostasis, like cardiac surgery using high-dose heparin.
So what testing do we add then?
Here, you'd consider adding platelet function testing, and the PFA 100 is generally preferred now over the old bleeding time. It's better for picking up things like von Willebrand disease or platelet dysfunction.
Okay, PFA 100, what else?
Still get your PT, APTT, platelet count, but maybe also factor 13 levels, especially if there's a history of delayed bleeding and possibly fibrinolysis screening.
And level 4 is for the highest suspicion cases.
Right. Level 4 is when you have a strong suspicion of abnormal hemostasis, pretty much regardless of the procedure. You do all the level 3 tests, plus consider factor 8 and IX levels for hemophilia and a thrombin time to look at fibrinogen.
It sounds like the PFA 100 replacing bleeding time is a key shift towards looking at function, not just numbers.
It really is. Just counting platelets doesn't tell the whole story, especially with something like VWD.
Okay, let's quickly recap those basic labs, PT, APTT, platelets. What's the core info they give us preoperatively?
So, the PT prothrombin time that mainly looks at your extrinsic and common pathways. It's the one that goes up with warfarin, obviously, but also argatrobin, high-dose heparin sometimes.
Got it. And APTT.
Activated partial thromboplastin time. That checks the intrinsic and common pathways. It's primarily used for monitoring unfractionated heparin therapy, but it'll also pick up things like lupus anticoagulant or hemophilia A or B.
And platelet count. Well, that's straightforward. Enough platelets for the initial plug.
Pretty much, just the quantity.
What about those other tests we mentioned, FDPs, ELT? When do they come into play?
Fibrin degradation products, FDPs, can be elevated when there's increased clot breakdown, like in DIC, cirrhosis, major trauma. But they're not very specific, Lots of things can raise them.
Okay, so suggestive but not diagnostic on their own.
Right. The globulin lysis time, or ELT, gives you a better global look at the fibrinolytic system. It can help differentiate primary fibrinolysis from DIC. Well, a shortened ELT without low platelets might suggest primary fibrinolysis. But if the ELT is short and the platelets are low, you're thinking more along the lines of DIC.
Okay, that helps clarify. So we've done the pre-op workup, now we're in the OR and things start going sideways, bleeding, Chapter 39 again. How do we approach managing perioperative coagulopathy?
first big distinction is inherited versus acquired problems. And then, is it a primary hemostasis issue, platelets, or secondary, the coagulation factors?
Let's start with inherited, von Willebrand disease you mentioned.
Yeah, it's the most common one you'll likely encounter. Remember the main types. Type 1 is a quantitative deficiency, less VWF protein.
Okay.
Type 2 involves qualitative defects. The VWF doesn't work right. And there are subtypes there, 2A, 2B, 2M, 2N, different functional problems.
Complex.
It can be. And type 3 is a severe near total absence. Treatment really depends on the type and severity.
Like DDAVP.
DDAVP works well for type 1 and some type 2s, boosting release of existing VWF. But for more severe types or non-responders, you need VWF concentrates.
Or factor VIII VWF concentrates.
Right. Cryoprecipitate used to be used, less so now. And crucially, tell symptomatic VWD patients to avoid NSAIDs. That's important.
Good point. What about inherited platelet disorders? Are they common?
Generally much rarer. You have giant platelet disorders like Bernard-Soulier, some MYH9-related ones, then Glanzmann thrombasthenia, which is a defect in the GPIA receptor needed for aggregation.
Treatment there.
Mostly platelet transfusions, maybe recombinant factor VIII in some tough cases, and then storage pool disorders where the granules inside the platelets are deficient.
Okay. Moving on to hemophilia, factors VIII and AX.
Hemophilia A is factor VIII deficiency, B is factor IX. Classic presentation is bleeding into joints, soft tissues. Diagnosis starts with a prolonged APTT, then specific factor assays confirm it.
And management.
Factor replacement is the mainstay. DDAVP can sometimes help in mild hemophilia A. The big challenge is inhibitors.
Antibodies against the factor.
Exactly. For those patients, you might need bypassing agents like recombinant factor A or activated PCCs. And there's emicizumab now, a non-factor therapy for hemophilia A.
Any special considerations with emicizumab?
Yeah, there's a potential increased risk of thrombosis if you use activated PCCs concurrently with emicizumab. Need to be cautious there.
Okay, let's shift to acquired coagulopathies. Vitamin K deficiency.
See that with malnutrition, malabsorption, or warfarin, obviously. Affects factors 2, 7, IX, X, and proteins C and S.
Reversal.
For immediate effect, FFP, or better yet, PCCs. Vitamin K takes longer but gives a more sustained correction.
And DIC. Disseminated intravascular coagulation. That sounds serious.
It is, usually triggered by something major sepsis, massive trauma, some cancers. Basically, the coagulation system goes into overdrive systemically.
So clotting and bleeding.
Paradoxically, yes.
Yeah.
You get widespread microthromby, consuming factors and platelets, and then secondary fibrinolysis kicks in, leading to bleeding. Diagnosis uses a panel. PT, APTT usually prolonged, low platelets, low fibrinogen, high D-dimer. The ICA score helps formalize it.
Management.
Fundamentally, treat the underlying cause. That's the most important thing.
And of course, we cause coagulopathy ourselves with drugs sometimes.
Absolutely. All the anticoagulants, antiplatelets, thrombolytics we use, they all fall into this category too.
Yeah, Chapter 39 also mentions the lethal triad factors, hypothermia, acidosis, dilution. Why are they so critical in surgical bleeding?
They form a vicious cycle. Hypothermia directly slows down the enzymatic reactions of the coagulation cascade. Platelets don't work as well either.
And the lab tests might not show it.
Right, because labs run the sample at 37 degrees Celsius. So you can get false reassurance. Keeping the patient normothermic warm fluids, forced air warmers, minimizing exposure is vital. Active rewarming if they get really cold.
Makes sense. Acidosis.
Acidosis also impairs enzyme function and platelet activity. Again, the key is treating the underlying cause. Maybe it's hypoperfusion needing volume or inotropes, maybe sepsis needing antibiotics and drainage. Sometimes preemptive bicarb if you anticipate a big reperfusion hit.
And dilution from massive resuscitation.
Yeah, pouring in crystalloid or even blood products without replacing factors and platelets proportionally just dilutes everything out. Factors and platelets drop below effective levels.
That's where the balanced transfusion ratios come in, like 1.1.1 FFP.platelets.PRBCs.
Exactly, learning from military trauma experience. Also, be aware some fluids themselves can interfere hydroxyethyl starches. Dextrans can impair platelet function or fibrin polymerization. Even hypertonic saline has some anticoagulant effects.
Lots to juggle intraoperatively. Let's talk about achieving hemostasis right there in the field. Chapter 39 covers tools and agents. Mechanical first.
Sure, electrosurgery is the workhorse. Monopolar for cutting and broader coagulation, but remember the grounding pad and be careful near nerves or in tight spaces. Bipolar is more focused, great for sealing vessels like with ligature devices.
Argon beam.
That's monopolar too, but uses argon gas to clear blood and allow diffuse surface coagulation. Good for oozing surfaces like liver or spleen.
And radiofrequency devices. Tissue link.
Those use RF energy with saline irrigation, seals tissue nicely, less charring.
Yeah.
But you have to keep the probe moving to avoid steam popping.
Okay. Then we have topical hemostatics, things you put directly on the bleeding spot.
Right. Gelatin sponges like gel foam provide a matrix for the clot to form on. Just be aware they swell, so caution in confined spaces. They're absorbed over weeks.
Oxidized cellulose. Surgical.
Good handling, comes as a fabric. Apply it dry for best effect. It also gets absorbed.
Collagen-based ones. Avitine, helatine.
These actively promote platelet adhesion and aggregation. They need functional platelets to work well. Use dry instruments, keep away from nerves, remove excess. Don't put blood salvaged from areas treated with collagen back into the cell saver clogs the filter.
Any other?
Polysaccharide spheres, like Traumadex, work differently. They absorb water, concentrating the clotting factors locally.
Now, the active hemostatic agents, they do more than just provide a scaffold, right?
Exactly. Thrombin is the prime example. Directly converts fibrinogen to fibrin. Comes as liquid, gel, powder. Recombinant human or human plasma derived are preferred now over bovine due to antibody risk with bovine thrombin.
Efficacy comparable.
Generally, yes. Recombinant is immunologically safer.
And sealants. Flow seal, tissue.
These combine thrombin and fibrinogen, basically mimicking the final step of clotting. They provide a physical seal plus active components. Flow seal, which is gelatin plus thrombin, has shown good results. Tisseel and Evasil are fibrinogen plus thrombin.
What about some of the newer agents? Chitin, chitosan, zeolite.
Right. Chitin and chitosan dressings like Hemcon or Traumostat seem to work by binding proteins, activating platelets, maybe causing vasoconstriction. Mineral zeolites like QuickClot are super absorbent, concentrating clotting factors by pulling out water.
Is there a downside to zeolite?
The original versions had a significant exothermic reaction that got hot. Newer formulations are better, but it's something to be aware of.
Okay, so surgery's done, patient's in recovery, and they start bleeding again. Post-op bleeding. What's a critical decision point?
It boils down to, is this surgical bleeding like a suture line leak, or is it medical bleeding due to coagulopathy? That's the first most crucial distinction.
Have you sort that out?
Labs help repeat PT, APTT platelet count. Fibrinogen is important too. Maybe FDPs or D-dimer, thrombin time if you suspect consumption like DIC. But clinical picture is key.
What if it looks like non-surgical coagulopathic bleeding?
Then you manage the coagulopathy. Is it an underlying disorder? Is it drug-induced? Is it residual effects from surgery, resuscitation, hypothermia, acidosis? You need to correct the specific deficiencies, reverse drugs if possible, warm the patient, correct acidosis, give appropriate factors or platelets.
And the key point is,
rushing a patient with primarily coagulopathic bleeding back to the OR often isn't the best first move. You need to address the underlying hematologic problem first.
makes perfect sense. Okay, let's shift gears to the drugs we use to prevent clots. Chapter 41, anticoagulant therapy. Starting with parenteral options, heparin.
Unfractionated heparin, the classic, works by activating antithrombin, which then knocks out thrombin, factor TIA, and factor ZAC. Also releases TFPI, given 5B for treatment, sub-Q for prophylaxis.
Monitoring.
Need to monitor with APTT for therapeutic infusions. But heparin's tricky variable response due to protein binding, heparin resistance can happen, clearance is dose-dependent, potential for rebound after protamine reversal.
And the big side effect everyone worries about.
Bleeding, of course.
Yeah.
But also HIT, heparin-induced thrombocytopenia. Always have that on your radar.
Okay. Low molecular weight heparin, LMWH. How's it different?
It's derived from unfractionated heparin, shorter chains. Also works via antithrombin, but it's more selective for inhibiting factor Zaire compared to thrombin.
Advantages.
Longer half-life, better bioavailability, much more predictable response. Less protein binding, so usually no need for routine monitoring.
Dosing.
Weight-based, fixed doses for prophylaxis or treatment, much more convenient, allows for outpatient VTE treatment. Still a risk of bleeding and thrombocytopenia, though much lower risk of HIT, typically.
Reversal.
Protamine only partially reverses LMWH. That's a key difference.
What about fondaparinux?
That's a synthetic pentasaccharide. Purely inhibits factor ZAGA via antithrombin. Given subcutaneously, long half-life.
Uses.
VTE, prophylaxis, sometimes initial VTE treatment. Big advantage is virtually no risk of HIT. It doesn't cross-react with HIT antibodies. So it can be an option if someone has a history of HIT.
Downside.
No specific antidote. Recombinant factor A might help based on volunteer studies, but it's not a standard reversal agent.
All right, moving to the oral agents. Warfarin, the old standby.
Vitamin K antagonist inhibits synthesis of factors 2, 7, IX, and proteins C and S, oral but slow onset.
Requires bridging.
Yes, absolutely need overlap with heparin or LMWH initially because proteins C and S drop first, creating a temporary prothrombotic state. Risk of skin necrosis if you don't bridge, especially in protein CS deficient patients.
Monitoring is key.
Constant INR monitoring, lots of drug and food interactions, genetic variability in metabolism, CYP2C9, BKO, RC1.
Reversing warfarin.
Vitamin K for slow, sustained reversal. For urgent reversal, 4-factor PCCs are now preferred over FFP, faster, less volume. Avoid RFEAA for warfarin reversal.
Then came the DOACs, the direct oral anticoagulants. Big change.
Huge change. You've got dabigatran, which is a direct thrombin inhibitor, and then rivaroxaban, apixaban, edoxaban. Those are direct factor XA inhibitors.
Main advantages over warfarin.
Predictable effect, fixed dosing usually, no routine monitoring needed for most patients, fewer interactions. Big advantages in convenience and often in safety profiles for things like VTE treatment or AFib stroke prevention.
Are there situations where warfarin is still preferred?
Yes, definitely. Patients with mechanical heart valves, significant antiphospholipid syndrome during pregnancy, maybe severe liver disease, some complex GI anatomy issues. DOACs are contraindicated in pregnancy and breastfeeding.
What about urgent surgery on a DOAC?
There's guidance suggesting if the drug level is less than 30 nanograms per ml, significant bleeding is unlikely. And importantly, we now have reversal agents.
Right. A darucizumab for dabigatran.
Yep, a specific antibody fragment.
Yeah.
And andexanet alpha for the factor XA inhibitors, rivaroxaban, apixaban, edoxaban too, theoretically.
Good to have those options. Okay, let's switch to stopping platelets from clumping. Chapter 42, antiplatelet agents. Aspirin first.
The original. Irreversibly inhibits COX-1, blocking thromboxane A2 production. Wide range of cardiovascular uses, even low doses work well.
Side effects.
Bleeding, GI upset mainly, rare allergy.
Perioperative management.
Depends on the balance of risks. Often continued for low bleeding risk procedures. Definitely continued for vascular surgery like carotid endarterectomy or stenting. For high-risk bleeding surgery, might consider stopping 7-10 days before, but that's an individualized decision.
Then the phenopyridines, the P2Y12 inhibitors, clopidogrel.
Clopidogrel is a prodrug, needs liver CYP450 enzymes, particularly 2C19, to get activated. Then it irreversibly blocks the P2Y12 ADP receptor.
That activation step is important.
Very. Genetic variations in CYP2C19 means some people are poor metabolizers and get less effect. Also potential for drug interactions with CYP inhibitors, like some PPIs. Used widely ACS, post-PCI, PAD, stroke prevention.
Side effects. Stopping before surgery.
Bleeding is the main one. Rare risk of TTP. Usually stopped 5 days before elective surgery. Routine genetic testing isn't generally recommended to guide dosing, though.
For sure.
Another prodrug, also irreversible, P2Y12 inhibitor, but it's activated more efficiently and consistently than clopidogrel. More potent. Mainly used in ACS patients going for PCI. Also higher bleeding risk. Stop 7-10 days prior.
Ticagrelor.
Different class, not a phenopyridine. It binds reversibly to the P2Y12 receptor. Also potent. Used in ACS.
Side effects besides bleeding.
Can cause dyspnea, sometimes hypertension or lipid changes. Also rare TTP. Stop 5-7 days before surgery.
Anticoagulant.
That's the IV P2Y12 inhibitor. Reversible, very fast on, fast off. Used only paraprocedurally during PCI.
Okay. What about phosphodiesterase inhibitors?
Dipyridamole.
Increases adenosine and cyclic AMP levels. Weak antiplatelet on its own. Combined with aspirin as agranox for secondary stroke prevention, also used for cardiac stress tests. Side effects like headache, dizziness, caution with coronary disease.
Cisalustazole.
That's a PDE3 inhibitor. Vasodilator and antiplatelet effects. Main use is for intermittent claudication in PIAD. Side effects like headache, palpitations, contraindicated in heart failure. Stop 2-3 days before surgery usually.
And the PAR1 inhibitor, Vorpaxar. Works on the thrombin receptor on platelets. Indicated for secondary prevention in patients with a history of MI or PA, usually added to aspirin or clopidogrel.
Key trial. Side effects.
The TRA2P trial showed it reduced acute limb ischemia and revascularization in the PA subgroup. But significant bleeding risk, including intracranial hemorrhage, absolutely contraindicated if history of stroke, TIA, or ICH.
Let's talk about DAPT, dual antiplatelet therapy, especially with coronary stents. Huge issue for us when those patients need vascular surgery.
Critical area. DAPT, usually aspirin plus a P2Y12 inhibitor, is essential after stenting to prevent stent thrombosis.
How long is DAPT needed?
Depends on the stent type. Bare metal stents generally need at least 30 days. Ideally, delay elective surgery past that. Drug-eluting stents, traditionally 12 months, but newer generations might allow stopping the P2Y12 after 3 or 6 months for elective surgery. Always a discussion with cardiology.
What if surgery can't wait and DAPT needs interrupting?
Try to continue the aspirin if at all possible. Stop the P2Y12 inhibitor for the minimum required time, then restart DAPT as soon as it's safe postoperatively.
Any other key trials involving antiplatelets or combinations in our patients?
Well, the COMPASS trial was important. Showed low-dose rivaroxaban plus aspirin was better than aspirin alone for reducing vascular events and major limb events in stable PADCAD carotid patients.
So adding an anticoagulant to an antiplatelet.
Right, a different strategy. And for carotid stenosis, aspirin is standard. DAPT with clopidogrel is beneficial short-term for secondary prevention after a TIA or minor stroke related to symptomatic carotid stenosis.
Okay, final major topic. Chapter 43, thrombolytic agents.
The
Clot busters. Brief history.
started with streptokinase, discovered from bacteria, then urokinase from human urine. Both activate plasminogen non-specifically. Later came recombinant agents aiming for more fibrin specificity.
Like alteplide.
Alteplase, or TPA, was the first major recombinant, more fibrin-specific. Then modifications like rituplase and tenecteplase were developed, offering longer half-lives or potentially easier administration, like single bolus for tenecteplase and AMI.
How are they given? Complications.
Can be systemic IV infusion or increasingly catheter-directed thrombolysis, CDT, sometimes with mechanical devices to help break up clot. Major risk, of course, is bleeding, especially intracranial hemorrhage. Also allergic reactions, mainly SK, distal embolization, catheter issues with CDT. Many contraindications to consider.
Key applications in vascular disease. Acute limb ischemia.
Yes, CDT is often a primary option for ALI, Rutherford class Uri, or III, maybe select IID, especially if symptom onset is less than 14 days. Trials like Rochester, Style, Topaz compared CDT versus surgery with mixed results on long-term outcomes, but often less initial physiologic stress with CDT, albeit sometimes with higher bleeding risk. There are specific dosing protocols for CDT using alteplase, rituplase, or tenecteplase. CDT, often pharmacomechanical CDT, is used selectively for extensive iliofemoral DVT to try and reduce post-thrombotic syndrome. Again, trials like Havantane and ATTRACT have explored this, showing potential benefits but also increased bleeding risk compared to anticoagulation alone.
What about occluded AV access?
Thrombolysis is very common there to restore flow. Various agents and techniques, including pharmacomechanical approaches, have been studied in trials like Rodkin and Cool.
And catheter clearance.
Yes, lower doses like alteplase cathflow, rituplase, or tenecteplase are used routinely to declot central venous catheters, including dialysis catheters.
Other uses: stroke, PEMI.
Absolutely. Systemic alteplase is standard for eligible acute ischemic stroke patients within the time window. For massive PE with instability, thrombolysis, systemic or CDT is indicated. And while PCI is now dominant for AMI, thrombolysis still has a role where PCI isn't readily available.
Rutherford's includes algorithms for some of these scenarios, right? Hemostatic assessment, thrombolysis pathways.
Yes, and they're really helpful as cognitive aids. The hemostatic assessment algorithm walks you through preoperative risk stratification, testing, and managing bleeding, whether it's surgical or medical.
And for thrombolysis.
There are algorithms outlining decision pathways for stroke, MI, acute arterial occlusion based on Rutherford class, helping guide whether lysis is appropriate, which approach, and so on. They provide a structured, evidence-based framework for complex decisions.
So bringing it all together, this deep dive across these chapters really highlights how crucial a solid understanding of hemostasis, thrombosis, and all these agents is for us.
Absolutely. It's not just about knowing the drugs or the tests, but integrating it all the patient's individual risks, the clinical situation, the specific procedure. It really demands a nuanced, risk-stratified approach.
It underscores that need for individualized care, weighing bleeding versus clotting risks constantly.
Every single time. There's rarely a simple one-size-fits-all answer.
Well, this has been a fantastic overview, synthesizing a huge amount of information into a practical framework. As always, we encourage you listening to go back to these chapters in Rutherford's, delve deeper, and keep up with new evidence as it emerges.
Definitely.
Think about your own challenging cases. Where could applying these principles more rigorously, perhaps using those algorithms as a starting point, potentially improve outcomes? What specific scenarios keep you up at night related to bleeding or clotting? That's where this knowledge really makes a difference. Thanks for joining us on this deep dive.